Good morning, and thank you all very much. I'd like to thank the organizing committee who invited me, and the remit that they gave me was that they wanted me to bring in the sort of clinician's perspective on things and tell you as a fetal medicine person what are the things that we are doing now, and to some extent, what are the standards that we expect from the labs when they do their serum biochemistry. So, can we connect? What has changed? The big change that has happened is that now we believe that the first trimester screening is the most important time in that entire pregnancy. Because till date, what used to happen, and this is completely random, that when women would come for antenatal care, we would see them once a month till 7 months, then fortnightly in the 8th month, and then weekly in the 9th month. And there is no logic to this pattern of antenatal care. It was decided in 1929 by a bureaucrat sitting in the Ministry of Health in the UK, and it was based on economics. There is no scientific basis on why we should be seeing women in this way. And now we believe that we need to, and indeed we have, turned this pyramid of pregnancy care, where we believe that we have to pick up problems at 12 weeks, sit there and triage these women into a low-risk group or a high-risk group. And if she is low-risk, let her go through routine antenatal care, and then spend the rest of our time trying to direct care to improve the outcomes in the ones which we've triaged to have a problem. So, at 12 weeks, we of course talk about aneuploidies because this is what we look at, but we've also started picking up structural anomalies, so things we were doing in the second trimester. So the level 2 anomaly scan now we brought it to the first trimester, and I'll show you how. Now, increasingly, because we can offer fetal therapy, we pick up twin-to-twin transfusion syndrome in the first trimester itself. We want to give risks for preterm delivery, and this is based on both the cervical length and maternal alpha-fetoproteins, which we've started measuring in the first trimester. Giving risks for preeclampsia, IUGR, using PAPE and PLGF and the uterine artery Dopplers to give risks for that, and also gestational diabetes. So the oral GTT we brought into the first trimester, so we can again pick up the women whom we need to direct care for. And subsequently, we sort of do the whole thing again at 36 weeks for other problems. But nevertheless, the main message which has to go out to all of you is that for us, the first trimester is a really important time for us to give risks for a host of conditions. When we talk about risks, we talk about numerical risks. We don't talk about, oh, you have a risk of, you've got a high risk or a low risk. We talk in numbers because we believe that you must measure what is measurable, and for even patient counseling, they can grapple with probability odds in numbers much more than sort of subjective things like high risk and low risk. So we start off with a priori risk, which can be the prevalence of the disease, or so for instance in a Down syndrome, if a woman is 20 years old, she would start off with a priori risk of 1 in 2,000, and then based on the biophysical markers, such as, say, the nuchal scan, the biochemical markers, such as the PAPE and beta-HCG, we would give her a specific risk for aneuploidy for her. And we do this for everything, apart from aneuploidy, for structural problems, for medical disorders, for preterm labor, and for fetal growth restriction. So let's sit there and talk about aneuploidy, because that is how first trimester started, and we've just extended it now. As you understand, over the years, it's becoming, prenatal diagnosis of trisomy 21 is becoming the main area of detecting trisomy 21. In the 80s, it used to be maternal age, but that has slowly gone down because the detection rate based on maternal age is barely 30%. It used to be sort of the old blood test, the second trimester test, but even that, I mean, this is UK data, but even that has come down. I know in our country we still are using second trimester much more. But what has actually come in is ultrasound, because ultrasound, has helped in bringing up detection much higher, so to about 60–70%. So an amalgamation of both biochemistry and ultrasound gives the best risks. The other thing which often comes up is that when first trimester came up, the thing was that actually, why didn't we ask women? Because there was still a body of people who believed that, well, you know, the triple test is there and it's working fine, so why do we need to make the effort to bring screening into the first trimester? And the reality is because women want it. And this study showed that even if you did screening and you asked women, look, if we can tell you if you've got a problem in the first trimester or the second trimester, what would you prefer? They obviously said, 98% said, well, the first trimester. If we sat there and said that, okay, if we do screening and we offer you an invasive test and the risk of miscarriage is higher in a CVS vis-a-vis an amniocentesis, would you still prefer that? They said, yes, we would still prefer that. If we told them that, well, some Downs babies, they die by the time they come to the second trimester, third trimester, and if we wait, maybe those spontaneous miscarriages would happen, would you still prefer the first trimester? They said they'd still prefer the first trimester. And the reality is, and this is the thing that I really have to emphasize to you, we women want to know their problems early enough, and they want things to be done early enough. And this is the most sort of important thing why we have to shift from second trimester screening to first trimester screening. It's because it is the best thing for women. If this is a busy slide, but essentially, this is the ISPD position statement on aneuploidy screening. This is the International Society of Prenatal Diagnosis, and essentially what it has listed out is acceptable forms of screening and how it performs. So if I look at the first trimester, and as the presentation goes on, I'll explain to you why we prefer doing the bloods at 10 weeks and the nuchal scan at 12 weeks. But if you look at the detection rate, that's about 80-odd%. However, the second trimester, and please note, the only thing that they have objectively validated is the quadruple test, because the triple test is an outdated test. The false positive risk of that test is too high. The detection rate is too low as compared to other tests that are available. So we have to do away. I have, for the last 6 years, in our center, we do not do the triple test at all. But if you also just look at the quad test, you can see it's around 60-odd%. So obviously, the first trimester is much better. If we look at what's a good way of doing things, that is doing the first trimester and the quadruple test, where we can integrate both of them together and bring up detection rates to about 93%. And even higher is if we integrate the first trimester, the quadruple, and the anomaly scan, the so-called genetic sonogram that we do, and then we can bring up detection rates to about 96%. But all of this is based on quality control. There is, you know, the detection rates that I'm talking about is when you are doing a sensitivity of 90%, it is absolutely dependent on having perfect quality control. This is a chart of the National Health Screening Program for aneuploidy. So this is a UK chart, and you can see what goes in to make sure that a country performs screening where they can roll out the program for the whole country. And you can see, so the regional and national level, they make sure that they train staff, they bring the public up to date, they plan the workforce, they organize publicity and so forth. And at the local level, that they make sure that the people who are performing and reading the diagnostic investigations are appropriately trained. They set up operational policies, record results, carry out interventions. I mean, the point is that it is both local and national. But in our country, we don't have it, because obviously aneuploidy screening is not a Government of India health priority, because there are other things there. So we actually are individually responsible for assuring quality in every aspect of it. And this is where labs come in. You have to assure quality because the detection rate goes down substantially. So what do we expect? All of you know, of course, that the beta HCG goes much higher in trisomy 21s vis-a-vis the PAPAs. Why, as you were saying, why we prefer blood being taken at an earlier date is because the discrimination between normal and low PAPAs is much more at around 8-9 weeks, 10 weeks than it is at 12 weeks. Whereas for beta HCG, actually, the discrimination is much more later on in pregnancy. So if one, so that's why that we want to stagger doing the blood versus the ultrasound. Why are we particular about the software that is being used? So we use the FMF software because of the fact that the results vary with different gestational ages because of the weight, because of the ethnicity of the women, whether she's a smoker, whether there's an IVF pregnancy, and if they are twins, whether they're dichorionic twins or monochorionic twins. So the fact that in these situations the PAPA levels anyway tend to be lower have to be factored in. So it is imperative that the history taking is accurate and that the software makes note of all these findings, because we are completely obsessive about it. Say, for instance, in an IVF pregnancy, we know that the PAPA levels are going to be higher. If we don't factor this in, we will tag a lot more women, we'll flag up a lot more screen positives than are actually there, just because we've not factored in the fact that in IVF pregnancies, the PAPA levels tend to be lower anyway. It is really important that the blood samples are handled properly. So in centers where they send blood across, the serum has to be sent rather than the whole bed, because the PAPA is much more unstable if it's the whole blood, whereas it's much tighter in serum. If temperatures are not maintained, you can look at the stability at 40 degrees over here of beta HCG, how much of a fluctuation there is. And the lab has to ensure this. I mean, we cannot ensure how you do it. I wish, like, as you will see, the FMF maintains the way I perform the test in, you know, I need to audit and I need to have a license to perform the nuchal scan. But how do I make sure that the labs are following the stringent guidelines, which you would have to do were you in the West? Because for me, in India, we have no body which is ensuring that people, the labs which are doing prenatal diagnosis, they are maintaining the standards they should. And this is something that I believe has to come in, because it really, you know, because we are on the other end of the spectrum and we get screen positive reports from the lab and they really are absolutely fine. We are doing amnios and we are doing CVSs, and you know, unless you know, the acceptable invasive testing rate is about 1 in 30. That means for every 30 procedures I do, at least one of them should come as positive. And that doesn't happen if, you know, even say in the second trimester, when you are doing much more of biochemistry, if you keep sending out screen positive. So I would entreat that anyone who is, all of you who are doing second trimester screening and first trimester, you need to make sure all your screen positives are kept to a level which is acceptable, which is a 5% false positive rate, or as in our center, we brought it down to a 3% false positive rate because of this sort of constant dialogue between us and the lab people. So this particular study looked at about 2.5 lakh women, which had 886 trisomy 21 pregnancies within that. And you can see for the PAPA at gestations of 8, 9, and 10, the discrimination between the euploids and the trisomy fetuses was much more evident. And this was the case with beta HCG towards the end of pregnancy, where the trisomy fetuses and the euploid pregnancies, there was much more discrimination here, whereas at 8, 9 weeks, there was a little bit of an overlap between the euploids and the trisomy 21. So the ideal situation would be for us to do a beta, the PAPA at 10 weeks, bring her for a scan at 12 weeks, and then again do a beta HCG at 13 weeks,